If you appreciate diving deep into the nuances of health and wellness, don't forget to subscribe and share this journey. Join me as I dive into the challenge of accurately diagnosing back strain like a pro doctor. Accurate diagnosis is crucial when it comes to treating back strain effectively. A misdiagnosis can lead to inadequate treatment, prolonged recovery, and even further injury. In fact, studies have shown that up to 20% of back strain cases are misdiagnosed, resulting in unnecessary tests, treatments, and referrals. This is why it's essential for healthcare professionals to get it right from the start. When it comes to diagnosing back strains, doctors often face a multitude of challenges. One of the most significant hurdles is the overlapping symptoms with other conditions, making it difficult to pinpoint the exact cause of the pain. For instance, herniated discs, spinal stenosis, and even medical conditions like fibromyalgia can all present with similar symptoms to back strain. This highlights the importance of taking a thorough patient history and conducting a comprehensive physical examination. Another pitfall doctors face is the reliance on radiological imaging, such as X-rays and MRIs, which may not always reveal the underlying cause of the pain. In some cases, these tests may even lead to overtreatment or misdiagnosis. Furthermore, back strain can also be caused by psychosocial factors, such as stress, anxiety, and depression, which can be easily overlooked if the doctor isn't taking a holistic approach. Doctors may also fall into the trap of not considering the entire kinetic chain when evaluating back strain. This means that they may focus solely on the affected area, neglecting the surrounding muscles and joints that could be contributing to the pain. By taking a more comprehensive approach, doctors can increase their chances of making an accurate diagnosis. In addition, language barriers and cultural differences can also impact the diagnostic process. Doctors must be aware of these potential pitfalls and take steps to ensure that they're communicating effectively with their patients. By doing so, they can gather more accurate information and make a more precise diagnosis. Accurate diagnosis, methods, and procedures. So how can doctors accurately diagnose back strain? Implementing a systematic and evidence-based approach is key. Here are the steps and procedures to enhance diagnostic accuracy. 1. Comprehensive patient history. A detailed patient history is the cornerstone of accurate diagnosis. Key elements include onset and duration. Understanding whether the pain is acute or chronic helps differentiate between various etiologies. Mechanism of injury. Identifying activities or events that precipitated the pain can indicate musculoskeletal strain versus other causes. Pain characteristics. Assessing the nature, sharp, dull, burning, location, radiation, and factors that exacerbate or relieve the pain. Medical history. Previous back issues, surgeries, chronic conditions, e.g. diabetes, osteoporosis, and psychosocial factors. Medication use. Current and past medications can influence both diagnosis and treatment options. 2. Physical examination. A thorough physical exam should assess inspection. Look for asymmetry, muscle spasm, or deformities. Palpation. Identify tender areas, muscle tightness, or spinal misalignments. Range of motion ROM. Evaluate flexibility and pain during movement. Neurological assessment. Test for strength, reflexes, and sensory deficits to rule out nerve involvement. Special tests. Utilize specific maneuvers to identify particular issues. Straight leg raise, SLR test, helps identify lumbar nerve root irritation or herniated discs. Schober's test assesses the flexibility of the lumbar spine. Faber-Patrick's test evaluates the hip joint and sacroiliac joints. 3. Diagnostic imaging. Imaging should be judiciously used based on clinical findings. X-rays, useful for detecting fractures, dislocations, or degenerative changes, not typically necessary for uncomplicated back strain unless red flags are present. MRI, magnetic resonance imaging, best for soft tissue evaluation including discs, ligaments, and nerves, indicated if neurological deficits or suspected herniated discs are present. CT scans, computed tomography, beneficial for detailed bone assessment or when MRI is contraindicated. Ultrasound, emerging tool for assessing muscle and soft tissue injuries, though not commonly used for back strain. 4. Laboratory tests. Generally not required for straightforward back strain, but may be necessary if infection, inflammation, or systemic conditions are suspected. Complete blood count, CBC, to identify signs of infection or inflammation. Erythrocyte sedimentation rates are, and C-reactive protein, CRP, elevated in inflammatory conditions. HLA-B27 testing, if ankylosing spondylitis is a consideration. 5. Differential diagnosis. Always consider and rule out other potential causes of back pain, such as radiculopathy, nerve root compression causing radiating pain, sacroiliitis, inflammation of the sacroiliac joints, vertebral fractures, especially in osteoporotic patients, malignancy, metastatic lesions or primary spinal tumors, infections, osteomyelitis or epidural abscess. Treatment protocols, medications, and procedures. Once a back strain is accurately diagnosed, implementing an effective treatment plan is essential for optimal recovery. Treatment typically involves a combination of pharmacological and non-pharmacological interventions. 1. Pharmacological management A. Non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen, 400 to 600 milligrams orally every 6 to 8 hours as needed. Naproxen, 500 milligrams orally twice daily. Ketorolac, 10 milligrams IV every 4 to 6 hours for short-term use in acute settings. B. Acetaminophen, dosage 500 to 1,000 milligrams orally every 4 to 6 hours, not exceeding 3,000-4,000 milligrams per day. Use for patients who cannot tolerate NSAIDs or have contraindications. C. Muscle relaxants, cyclobenzaprine, 5 to 10 milligrams orally 3 times daily. Methocarbamol, 1,500 milligrams orally 4 times daily initially, then taper as needed. Baclofen, 10 milligrams orally 3 times daily, adjustable based on response. D. Topical analgesics, diclofenac gel, apply 2 to 4 grams topically to the affected area up to 4 times daily. Capsaicin cream, apply a thin layer to the affected muscles 3 to 4 times daily. E. Opioids, tramadol, 50 to 100 milligrams orally every 4 to 6 hours as needed for severe pain. Codeine, acetaminophen combination, use with caution due to addiction risk, typically reserved for short-term use. Note: opioids should be used sparingly and only when other treatments are ineffective due to the risk of dependence and side effects. 2. Non-pharmacological interventions. A. Physical therapy modalities, heat therapy, cold packs, electrical stimulation. Exercises, stretching, strengthening, and aerobic conditioning tailored to patient needs. Manual therapy, techniques such as massage, mobilization, and manipulation to reduce muscle tension and improve mobility. B. Chiropractic care, spinal manipulation, performed by trained professionals to alleviate pain and improve spinal function. Frequency, typically once or twice a week initially, then adjusted based on patient response. C. Acupuncture. Procedure, insertion of fine needles at specific points to relieve pain. Sessions, usually 6 to 12 sessions over several weeks. D. Education and ergonomics. Posture training, teaching proper posture during daily activities. Body mechanics, instructions on safe lifting techniques and movement patterns. Ergonomic adjustments, recommendations for workplace or home environment modifications to prevent recurrence. 3. Advanced interventions. A. Epidural steroid injections. Indication, severe pain with radicular symptoms not responsive to conservative treatment. Procedure, injection of corticosteroids and anesthetics into the epidural space under imaging guidance. Dosage typically 40 milligrams of methylprednisolone or equivalent per injection. Frequency up to 3 injections per year. B. Radiofrequency ablation. Indication, chronic pain due to facet joint arthritis or other specific sources. Procedure, use of radiofrequency energy to disrupt nerve conduction and reduce pain signals. Frequency can be repeated every 6 to 12 months as needed. Surgical intervention. Indication, rarely required for simple back strain, but may be necessary if there is an underlying structural issue such as herniated disc or spinal instability. Procedure, varies based on the condition, could range from minimally invasive discectomy to spinal fusion. Postoperative care includes physical therapy and gradual return to activities. Preventive strategies. Preventing recurrence of back strain is as important as treating the acute episode. Strategies include regular exercise, engage in activities that strengthen the core muscles and improve flexibility. Weight management, maintain a healthy weight to reduce stress on the spine. Smoking cessation, smoking impairs blood flow to spinal tissues, increasing the risk of injury. Stress management, techniques such as mindfulness, yoga, and meditation can help reduce muscle tension related to stress. Conclusion. Accurate diagnosis and effective treatment of back strain require a comprehensive and methodical approach. By conducting thorough patient evaluations, utilizing appropriate diagnostic tools, and implementing evidence-based treatment protocols, healthcare professionals can enhance patient outcomes and reduce the risk of misdiagnosis. Combining pharmacological interventions with physical therapy and lifestyle modifications ensures a holistic management plan tailored to each patient's unique needs. Thanks for watching. And if you have any experiences or questions about diagnosing back strain, please leave them in the comments below. And if you're new here, consider subscribing for more medical insights and tips.